All right, thanks, Kirk. My name is Justine. I'm just finishing up my regional anesthesia fellowship at St. Paul's Hospital in Vancouver. And today I'll be talking to you a little bit about the adductor canal block. And the image in the background here is actually a photo from the session that Kirk was talking about, where we did the remote coaching of the adductor canal block in Revelstoke, with us sitting comfortably in our office in Vancouver. So it was a really great experience, and hopefully more of you will be able to have that opportunity too through this program. So just to start, I have no disclosures. And the objectives of the presentation today will review the rationale for performing an adductor canal block. We'll describe the innervation of the knee as well as the anatomy, the sonoanatomy of the adductor canal. We'll review the indications and contraindications for the block, and we'll explain how to perform the block, what the appropriate target is, and how to assess for a successful block. And if you have questions throughout the presentation, put them in the chat, or we can talk about it at the end. So to start, what is the rationale for the adductor canal block, or why has it become so popular? And the main reason is because you can achieve knee analgesia without impairing ambulation. So classically, surgeries like total knee replacement, ACL repair were done with a femoral nerve block, but unfortunately, because the femoral nerve is a motor and a sensory nerve, it's associated with quadricep weakness, delaying ambulation and potentially increasing the risk of falls. So that's very much become less popular for knee surgeries, where ambulation and early mobilization have become so important. So the advantage of the adductor canal block is that it spares motor function of 3 of the 4 quadriceps muscles and does retain most of the quadriceps baseline strength. The study suggests that performing an adductor canal block compared to a femoral nerve block, the pain or patient satisfaction is about the same. So we're not losing much in terms of analgesia with the adductor canal block compared to the femoral nerve block. And the study suggests that doing an adductor canal block, in addition to any local place by the surgeon, is superior to doing either alone in total knee arthroplasty. So we'll just quickly review the lower limb dermatomes, osteotomes, and myotomes. So the main innervation of the knee is from the femoral, of which the saphenous nerve is a branch, as well as the obturator nerve anteriorly and medially. And then it's primarily the sciatic nerve and its branches which innervate the knee posteriorly and laterally. So in this picture of the osteotomes here, the saphenous nerve is in pink, and you can see right over the patella, the anterior medial knee is right where that block would be covering. And as we'll find out, the adductor canal is primarily a saphenous nerve block, although there are a few other nerves that we'll talk about. So then we'll talk about the anatomy of the adductor canal. So the adductor canal is basically a tube in which nerves as well as the superficial femoral artery and vein run. It extends from the apex of the femoral triangle, which is essentially where the medial border of the sartorius and the adductor longus meet. So that's the top of the adductor canal. And the bottom is the adductor hiatus, which is the end of the tube where the artery and the vein become the popliteal artery and vein and travel down posteriorly. So in the yellow box is basically the adductor canal. The borders of the adductor canal are muscles. So anteriorly we have the sartorius, laterally we have vastus medialis, and then medially we have the adductor magnus and longus. So as I mentioned, the adductor canal contains the superficial femoral artery and vein. And then the 2 nerves that primarily we're interested in is the saphenous nerve, which is a purely sensory nerve, and the nerve to vastus medialis, which is a motor and a sensory nerve. So it covers one of the quadriceps, vastus medialis. It may contain a few other small nerves, such as the medial femoral cutaneous nerve, articular branches from obturator, as well as other small branches of the saphenous nerve. But the main 2 that we are aiming to cover are the saphenous and nerve to vastus medialis. So now that we've talked about the anatomy, we can talk about the sonoanatomy or the ultrasound anatomy. So unfortunately, the proximal and distal ends of the adductor canal don't correlate well with surface landmarks on the legs. So mostly you're relying on your ultrasound image to know where you are within the adductor canal. And so that's demonstrated in this picture with A, B, and C. So the top of the adductor canal, or the apex of the femoral triangle, is at A. And on your ultrasound image, you'll see the superficial femoral artery is medial to the sartorius. At B, which is probably the ideal place to perform the adductor canal, the artery is right under the sartorius. And it's good for a few reasons. So one, it's quite a superficial spot for the artery to be compared to down at C near the end of the adductor canal at the adductor hiatus, where the arteries often dove quite a bit deeper, and so it can be more challenging to get there. And then also you're more likely to have nerve to vastus medialis well covered if you're in the mid adductor canal. The saphenous nerve lies laterally to the femoral artery in the proximal thigh, but as you travel more distally, it goes over the top of the artery and then becomes medial. So again, if you're at the B or the mid adductor canal, most likely it's going to be lateral, whereas again, if you're going too distally and you're targeting your local anesthetic in the lateral area of the artery, you may be missing the saphenous nerve. And this is just another picture illustrating that the adductor canal is a tube, and then the three key locations where we think about blocking in the adductor canal. So just to quickly summarize, the saphenous nerve and the nerve to vastus medialis largely cover the anterior medial area of the knee. So that's useful, as we'll see in a number of surgeries where the surgical approach is the medial knee. The only motor nerve potentially to be anesthetized is the nerve to vastus medialis. The saphenous nerve is a purely sensory nerve. There's also some theoretical spread proximally and distally. So potentially using a very large volume of local anesthetic, you may cover the femoral nerve, and then distally, potentially you could cover the sciatic nerve. But again, that's pretty theoretical in practice. It's mainly those other two nerves that we're blocking. So then you might ask, so what are some indications for performing the adductor canal block? For us here in Vancouver, the main reasons we would use the adductor canal block are primarily total knee arthroplasty, as well as foot and ankle surgeries where we're aiming to get a surgical block so the procedure can be performed just under the block. There's also quite clear benefit for chronic pain, opioid tolerant patients having minor arthroscopic knee surgeries, or as a rescue block after minor knee surgery. There have been a few cases here where we've had patients who've had a fairly small procedure who did not receive a block preoperatively, were having a lot of difficulty in PACU, and performing this block actually made quite a big difference for those patients. There's a little less clear evidence in terms of ACL repair. There's some conflicting studies that show perhaps just local by the surgeon may be enough, but there's been no study showing the combination of the adductor canal block and local anesthetic together by the surgeon. So it's a little unclear if there's really no benefit, but I think potentially there is. It's also probably beneficial in things like patellar fracture. As we saw from the first picture, the saphenous nerve covers the patella quite extensively. And then also in below knee amputation, we know that the saphenous nerve would play a role in that. It's likely not beneficial in just a straightforward minor arthroscopic knee surgery. I think it's been pretty well established that local by the surgeon for that is quite adequate. And so there are very few contraindications to the adductor canal block. It's primarily the ones that we usually think of, like patient refusal, allergy to the local anesthetic, infection over the site. Relative contraindications would be previously existing neuropathy. So if there's any history of neuropathy, you want to document that quite well and have a risk and benefit discussion with the patient. Also, I've had a few blocks where the patients had a vascular procedure. And so there's one artery that is pulsatile and one artery that is very much not pulsatile. So it can be just very difficult to find the correct spot, and then risk of graft puncture where it would not be able to heal itself and potentially cause a hematoma is something you have to be aware of. And then coagulopathy, this block is considered to be intermediate risk for bleeding complications. But as you'll see in the coming pictures, the superficial femoral vein is right in the area where you're aiming your needle. So it's quite important to see that as it's relatively high risk for vascular puncture if you don't identify that vein. So next we'll talk a little bit about the supplies and the setup. I think there'll be some future sessions that go over this in a little bit more detail, but quickly you should have all your usual CAS monitors. So when you're looking for things like local anesthetic, systemic toxicity, having your ECG and looking for arrhythmia is quite important. So having that in addition to your oxygen saturation and your blood pressure monitoring. You should have your resuscitation drugs available. And whenever you're doing any block, it's important to make sure the operative side is marked, that you've clarified that with the patient through a safety check and review any allergies. We typically use chlorhexidine and alcohol for our prep. We use a sterile technique with gloves, as well as a high frequency linear probe with a sterile cover over top. You'll need a syringe and a 25 gauge needle for skin local. We typically use 1% lidocaine for that. And then we use an 80 millimeter nerve block needle. The shorter needles, I think in most patients will probably not reach. So using the 80 millimeter needle is probably the ideal. And then the positioning is well shown on this picture here. So essentially what you do is you have the patient flex their knee and then externally rotate. We often say, put your leg out like a frog leg, and people seem to understand what that is. I often put a pillow or a folded blanket underneath the knee to support it, because many of these patients have reduced mobility in their leg, especially patients coming for total knee arthroplasty. Less of a problem with the ACLs usually. And then in terms of your local anesthetic, 10 to 20 mils of a long-acting local anesthetic like bupivacaine or ropivacaine. And the last time I gave this session, I said we used 0.5% ropivacaine pretty routinely here, but I think it was brought up in our chat and questions after. A more dilute local anesthetic would be completely appropriate because we're aiming for a sensory nerve block. So 0.25% bupivacaine or ropivacaine, 10 to 20 mils would be completely appropriate. It's just important that if the surgeon is also going to be doing some local infiltration, make sure that the maximum safe dose is not exceeded. It's quite easy to exceed that dose in thin patients. And so then in terms of technique, we use an in-plane approach. We scan for the femoral artery and short axis in the mid-thigh. And for a left-sided procedure, I typically have my ultrasound probe here with the lateral on the left side. And then if I'm doing a left-sided procedure, I have my lateral on the right side. And that just, for me, lines it up anatomically. I found it when I was first starting to do this block, it was very easy to get mixed up on which side is lateral and which side is medial. And it's very important because we're aiming for the lateral side of the artery. So just make sure whatever way you have your ultrasound set up, that it makes sense to you and you're well aware of what's lateral and what's medially. Beginners, I found again when I was starting, you tend to search more laterally to start, and with that you'll probably see the femur, and that's a sign that you should move your ultrasound probe more medially. And then I tend to scan up and down the leg looking for that perfect spot where the artery is right underneath the sartorius. And then I make sure I also identify the superficial femoral vein. And sometimes it's more over to the lateral side, and by scanning up and down, you may find a spot where it's well away from your target and less likely to have a vascular puncture there. So again, as I mentioned, we typically use an in-plane approach. I've not seen an out-of-plane approach, so that's what I'm most comfortable with. The target is typically 2 to 4 centimeters of depth below the skin. With larger patients, it may be deeper, and a strategy for that is just to continue to go more proximally, because as you go more distally in the leg, the artery dives down and then becomes a much deeper target, making it more difficult to line up your needle with your ultrasound probe. The goal is to deposit local anesthetic below this layer called the vasto-adductor membrane. It's a very thick fascial layer, and it's really important in the performance of the adductor canal block for the reason that you really need to be below this layer. And then when you're below this layer, when the local anesthetic is deposited, you tend to see the artery dropping down or becoming compressed. Whereas if you're above this layer, you tend to see the sartorius going up. So the sartorius being lifted is an indication that you're not in the correct place. So it's quite important to be below the vasto or vasoadductor membrane. So the technique is to advance the block needle from lateral to medial through the sartorius muscle. You may feel a little bit of a pop as you go through the vastoadductor membrane, or you may see a little bit of give on the screen. The saphenous nerve is quite difficult to visualize before you've begun to deposit your local anesthetic. After that, it often becomes more obvious with a nice pool of local anesthetic around it. It's typically at the 9 to 11 o'clock position. So when I'm putting my needle in, I tend to try to go around either 5 o'clock or closer to noon or 1 o'clock because I don't want to enter the nerve itself. So once you're in the target location, the idea is you inject your local anesthetic in 5 milliliter aliquots, checking aspirations negative every 5 milliliters. Because often in larger patients or people with very thick legs, you're really putting a lot of pressure on that ultrasound probe, and that will compress the femoral vein quite easily. So it's very important to make sure that aspiration is negative. As I mentioned, the ideal placement of the needle will result in local anesthetic spreading circumferentially around the artery and pushing it down. It's important to see a nice black layer. You don't want to see any gray or potential expansion into the saphenous nerve. So seeing nice black creating a pool around us the nerve is what you want to see. If you see that linear lifting of sartorius, which I'll show you in a video coming up, you haven't gone through the vasoadductor membrane yet, and you need to proceed on. So this is the first video, and it shows what I think is a pretty good example of all the different anatomy you need to see, and then what good local anesthetic spread looks like. So in this case, they are really right in the middle of the sartorius muscle with the artery right underneath. And you can see that the vein is very hard to see, so it can be important to identify that. And so they're coming in laterally to medial to the lateral side of the superficial femoral artery there. And then you'll see a little bit of a pop or a give as they enter that vasoadductor membrane. So they're starting to inject some local, and you can really see how compressed that artery is getting. You're not really seeing much sartorius lift. It's really, you see this nice spread over top of the artery. All right. And then in this next video, I think this is a really good video because there's multiple injections of local anesthetic above the area that you want to be. So it really shows the difference of what the target looks like versus what would be incorrect spread, which is really easy to do. Oh yeah, there is some music. So this time it's opposite. So this is lateral over here, just to clarify. So it's been flipped. So they're coming in kind of through the sartorius here. And so to start, you see this kind of linear spread. And so you really see sartorius lift. You're not really seeing any depression of the artery there. They do this kind of multiple times, searching for the right spot. And so this is the vasoadductor membrane that they're going to try to get below, which I think they end up doing in this. And so then you see this very dramatic drop in the artery, which is right in the location where you want to be. So in the first video, they kind of went around 5 o'clock. In this one, they kind of went around 1 o'clock. So both kind of avoiding what they think is the saphenous nerve. So I guess what about nerve stimulation? We've talked about ultrasound. So it can be useful if you'd like to use it. Using the nerve stimulator at 1 milliamp can be used in conjunction with the ultrasound. And so when you're using it, the patient will experience a tapping sensation at the medial malleolus. So you just kind of warn them that as you're getting close to the nerve, they may feel that sensation. If you're using the nerve stimulator, make sure that you turn it down and sensation is lost by 0.2 milliamps. If you have stimulation below that, it's a suggestion that perhaps your needle is intraneural and it should be withdrawn and redirected. So I think it's really important to assess your block after it's done. I think it gives you a lot of feedback. So for when blocks fail, you can go back and think about what the image looked like. And then when you have a successful block, go back and think about what the image looked like. So over time, you develop your skills. Because it's small sensory nerve, the onset of the block is quite rapid. So within 5 to 10 minutes, the easiest place to assess it is at the medial malleolus. So they should have reduced sensation on that side compared to the other side. It's a little bit difficult to assess that right at the knee. So I think the medial malleolus is quite specific for the saphenous nerve. So I think that's the best place to check it. So complications, overall, very low risk for complications, which is good. The three main complications that we think about are nerve injury, intravascular injection, and vascular puncture. So nerve injury, pretty uncommon, which is good. And overall, if it were to happen, it tends to resolve over time, which is good. When these nerve injuries happen, it could be secondary to nerve block, such as direct injury, intraneural injection, or secondary to hematoma formation, or it also could be secondary to surgical technique or the thigh tourniquet. So it can be a little bit non-specific, but it's important just to follow when anyone identifies a nerve injury that it does resolve over time. I think intravascular injection is fairly it's something that happens frequently with this block, especially when you're just starting out. So it's important to be aware of that because there are case reports of rapid onset of local anesthetic systemic toxicity from an unrecognized intravascular injection in this case. Vascular puncture, as I mentioned, also a potential risk. There's many case reports of hematoma, arterial dissection, or pseudoaneurysm formation. Again, the hematoma or bruising could be confounded by having the thigh tourniquet on as well. So just important to identify any of these complications and follow them. So overall, the adductor canal is a sensory block which primarily covers the anterior medial aspect of the knee, as well as the medial calf and ankle. It's quite useful for painful procedures of the knee, including arthroplasty. And the block site is sonographically where the superficial femoral artery is right below the sartorius muscle. It's usually in the mid-thigh, but again, you can't necessarily find it from landmarks alone. The goal is to deposit local anesthetic lateral to the artery below the vasoadductor membrane, resulting in local anesthetic spread lateral to and over the artery. And then just be aware that intravascular injection is possible and inject your local anesthetic after aspiration slowly and in 5 milliliter increments. You want to see a nice black pool of local anesthetic, and you want to be monitoring for any potential local anesthetic systemic toxicity. And this is just a summary sheet just summarizing all the things that you need and your approach to the adductor canal block. Thank you.
That's great. It's 8 minutes to 7. We don't need to take up the whole hour. If everybody is happy and there are no other questions, we can certainly bring the meeting to an end early. Unless there's any other comments.